Alterations in cardiac output and tissue perfusion, the infectious and inflammatory disorders. Rheumatic fever and rheumatic carditis. Rheumatic fever follows a group A streptococcal infection, and rheumatic carditis is an inflammatory cardiac manifestation of rheumatic fever. These clients may experience a mild fever, a rapid heart rate, abnormal rhythm, red spotty rash on the trunk that disappears quickly but leaves irregular circles on the skin, swollen joints, warm, red, and painful, heart murmur or pericardial friction rub, and chorea. These clients are diagnosed with EKG that might show some heart changes, but there is no specific lab test. However, an ESR or a CRP or C-reactive protein might be elevated. We treat it with IV antibiotics such as penicillin, vancomycin, zithromax. These clients may require surgery for constrictive pericarditis or damage to the heart valves. And we're going to administer aspirin for clot prevention, steroids, and prophylactic antibiotics prior to any invasive procedures to help prevent complications. Nurses make sure that we're administering prescribed drug therapy, doing diversion activities, encouraging bed rest, giving small, frequent meals, sodium restrictions, increasing fluids, protein and calories may also be required. Infective endocarditis is inflammation of the inner layer of heart tissue, and it's considered to be an autoimmune response. Microorganisms that cause it include bacteria, streptococci, and staphylococci, and fungus. Causes include prolonged IV therapy and insertion of cardiac pacemakers, cardiac catheterization, and a Foley catheter. These clients acutely may see fever, chills, malaise, muscle aches, joint pain, Osler nodes, splinter hemorrhages, Janeway lesions, Roth spots, petechiae, an enlarged spleen, and they may have a heart murmur. Vegetations from this infection, because this infection is on the valves, they can break off and cause emboli. These clients may be experiencing, or they're diagnosed because they may have anemia, leukocytosis. We also diagnose with blood cultures and transesophageal electrocardiography or an ECG. We treat it with high doses of IV antibiotic therapy, bed rest, and may require valve replacement. These clients need to limit their activity. Nurses need to assess for changes in their weight, their heart rate, and their heart rhythm, and administer those antibiotics as prescribed. So, which of the following histories of a client would relate to a diagnosis of bacterial endocarditis? And that's B, the one that had strep throat 4 weeks earlier. Pericarditis is inflammation of the pericardium. It can be primary or secondary. If it's secondary, it would be secondary to endocarditis, myocarditis, chest trauma, myocardial infarction, and post-cardiac surgery. It can lead to a fluid accumulation that can lead to cardiac tamponade. In other words, we have a fluid accumulation between the heart and the lining of the heart, and that it creates a tamponade effect by reducing the ability of the heart muscle to contract. This causes that acute compression of the heart, and then we may also see pulsus paradoxus. These clients may have a fever, malaise, heaviness in their chest, precordial pain, movement and breathing worsen the pain, but sitting upright and leaning forward can actually relieve the pain. They may have a pericardial friction rub and severe hypotension. We diagnose by looking at the ST segment of the EKG. It will be elevated. Look at chest x-ray, echocardiogram, white blood cell count, and your erythrocyte sedimentation rate, which shows inflammation. We treat it medically with rest, analgesics, antipyretics, NSAIDs, and corticosteroids. Surgically, it may require a pericardiocentesis where we drain that fluid from around the heart, pericardiostomy, a pericardiectomy, or a decortication. Nurses monitor pain. We auscultate frequently the heart sounds, check for jugular vein distension, persistent cough, dyspnea, fainting, anxiety, or changes in the pulmonary function. So a client with pericarditis has been admitted to the cardiac intensive care unit. The nurse caring for the client knows that the most common clinical assessment of pericarditis is what? Select all that apply. This is all of the above. Thrombophlebitis is inflammation of a vein accompanied by a clot or thrombus formation. That's our deep vein thrombosis. And it can also lead to the pulmonary embolus. The inner vein is irritated or injured, and then platelets start to clump together and it forms that clot. We may see the Virchow's triad, which is venous stasis, altered blood coagulation, and trauma to the vein. We also see an increased risk for a thrombophlebitis with inactivity and oral contraceptives, especially with smoking. These clients have discomfort in the affected extremity, calf pain that increases on dorsiflexion, which is called the Homan sign, heat, redness and swelling, capillary refill is decreased, fever, malaise, or capillary refill length of time is increased. We see fever, malaise, fatigue, and anorexia. We can diagnose with a Doppler ultrasound, a venography, and an IPG. Medically, initially we want to ambulate the client to help prevent blood stasis, but if they develop, we may do some anti-embolism stockings, anticoagulant therapy, and continuous warm, wet packs. Elevation of the extremity because of the edema. Surgically, we may do a thrombectomy or ligation, and clients that are prone to DVTs, have had several of them in the past, may also have a vena cava filter that is placed usually in the femoral vein to help prevent emboli from traveling to the heart and lungs. So nurses need to assess for a history of blood clots. What are their risk factors, such as obesity, contraceptive use? Check that Homan sign. Check the cap refill, and check for any signs or symptoms of a pulmonary embolus, such as chest pain and dyspnea. And arteritis is inflammation of the arteries, and it damages the blood vessel walls and reduces blood flow to the organs. Symptoms and complications will depend on which arteries are affected and the degree of damage. Tachyosis arteritis is also known as the aortic arch syndrome or nonspecific aortaritis, in which the walls of the aorta grow thicker, and it leads to an insufficient blood and oxygen supply to the rest of the body. Complications can include a loss of vision, cardiac disease, hypertension, fainting, joint pain, muscle pain, fatigue, malaise, fever, night sweats, weight loss, and aortic aneurysms. The giant cell arteritis or temporal arteritis is an infection of the superficial temporal artery and those other arteries that supply blood to the head, eyes, and jaw. The giant cell arteritis generally starts out with flu-like symptoms and includes severe headache, fever, aches, loss of appetite, and malaise. Complications can result in vision loss, jaw pain, scalp pain, and other symptoms. And then we have polyarteritis nodosa, which is an inflammation of the medium and smaller arteries that carry blood from the heart to organs and tissues. These symptoms also include headache, fever, muscle aches, joint aches, fatigue, weakness, anorexia, rashes, sores that look like bruises, pain, burning, numbness, weakness in the hands and the feet, renal failure, high blood pressure and edema, heart attacks, heart failure, and pericarditis. The cause is unknown, but it is believed to be an autoimmune disorder. We treat it with corticosteroids, antibiotics, surgery. Most people will recover, but treatment may take a year or two.